Halo, Assalamualaikum warahmatullahi wabarakatuh. Meet me Rahmi again in this the best occasion in front of you all in the YouTube video. Okay, nice to see you here, and I'll tell you about the dietary management in type 1 diabetes. For the house college students, you can hear this. Why? Because I can't explain for you all how describe how insulin management can be personalized for individual clients, outline methods for carbohydrate counting, identify types of insulin and their action curves, calculate typical carbohydrate insulin ratios and insulin sensitivity factors, identify and manage symptoms of hypoglycemia. The last ones recognize the role of a certified diabetes educator. Okay, let's talk background of type 1 diabetes. Type 1 diabetes is an insulin deficiency that results from pancreatic beta cell dysfunction. While the underlying cause of this disease remains unknown, it is thought that genetics and undetermined environmental factors contribute to an autoimmune destruction of the pancreatic beta cells. Type 1 diabetes is cyclically present during childhood and adolescence, but can occur at any age. When our body loses the ability to produce insulin, glucose transport into cells is impaired, and hyperglycemia results. Individuals with type 1 diabetes who produce insulin are at risk for diabetic ketoacidosis, a potentially fatal condition of hyperglycemia, accelerated ketone production, acid-base imbalance, and dehydration. Long-term complications of hyperglycemia include neuropathy, retinopathy, heart disease, and stroke. Exogenous insulin must be administered on a daily basis to control blood sugar and prevent both hyperglycemia and ketoacidosis. Insulin must be balanced with diet to promote normal blood sugar and prevent hypoglycemia. I have the cases for you. One case, the patient is a 30 years old man with type 1 diabetes, diagnosed at age 13. He presents to the endocrinologist on 50 units of insulin glargine every evening and 3 units of lipsro with each meal. His hemoglobin A1C is elevated at 8.1% and he has experienced several instances of severe hypoglycemia in the last few months. The most recent causing loss of consciousness that resulted in his wife's calling 911. He is seeking another option regarding his insulin regimen and diet. During the first office visit, the endocrinologist determined that the client had no evidence of diabetes complications such as renal failure or cardiovascular disease. However, there was tremendous concern regarding the increased severity and frequency of the client's hypoglycemia. His glargine dose was decreased to 40 units. He was sent to the registered dietitian or RD for diabetes education as he had not received education since the time of his initial diagnosis. Meal planning is a cornerstone of diabetes self-management, and use of carbohydrate counting is one method of diabetes meal planning. Carbohydrate counting allows people who use rapid-acting insulin before meals to fine-tune their primal dose based upon the amount of carbohydrates they plan to eat. They are introduced to the concept of matching insulin to food intake and calculating insulin dose based upon the carbohydrate content of a meal or snack. She also recommended that he attend an insulin management program that would cover the concepts of a basal prandial insulin, onset, peak, and duration of different types of insulin, and B. proper storage and administration of insulin. The RD helps him to determine his insulin carbohydrate ratios, which will help him to know how much rapid-acting insulin to administer at meal times. Two common methods are used for assigning carbohydrate ratios to a patient. First, 500 rule, where the insulin to carbohydrate ratio is derived by taking the total dose of all insulin taken in 24 hours and dividing it into 500. The result would usually be rounded to the nearest whole number. It is also common to start with a ratio of 1 unit of insulin to every 15 grams of carbohydrate and adjust upward or downward after observing 2 hours postprandial and premeal blood glucose values for several days. Once a carbohydrate to insulin ratio is determined, the patient counts carbohydrate grams for each meal, and then administers the appropriate prandial dose of insulin to cover the meal. The RD also teach him how to determine an insulin sensitivity factor, which helps to determine the dose of insulin that will correct a high blood sugar. Two methods are generally used to assign insulin sensitivity factor to a patient. First, 1800 rule derived by taking the total daily dose of all insulin and dividing it into 108 Second, start with a sensitivity of 50 and adjust it upward or downward after observing blood glucose levels for several days. In this case, 1 unit of insulin would be expected to drop the blood sugar by 50 units. Using this method, if the blood sugar is high before a meal, the correction dose is added to the prandial dose. Although the insulin sensitivity is typically 3 to 4 times the carbohydrate ratio, patients may have different carbohydrate ratios and sensitivity at different times of the day. Generally, approximately 40% to 50% of insulin requirements are given at basal insulin, and the remainder is divided up in meal times and snacks. Okay, friends, that's all my presentation. I hope that you will be happy to hear my presentation, and we meet again in the next time. Okay, see you. Bye bye.